evening and welcome to tonight's webinar, Understanding Dementia, A Way Forward. I'm Janine Grossman, Director of Professional Services at Montefiore. Before we commence, I would like to acknowledge that we are here today on the land of the Gadigal and Bidjigal people who traditionally occupied the Sydney coast. On behalf of Montefiore, I acknowledge Aboriginal or Torres Strait Islander people attending this evening and pay my respects to elders past and present. We are thrilled that we have over 200 people joining us online tonight as we launch our new Montefiore speaker series, shining a spotlight on all the issues that affect older members of the community and their loved ones. Each session, currently online, will explore an aspect of the aging experience, including health and wellness, research and innovation, making the right choices in aged care, and supporting older family and community members. You'll have the opportunity to hear from visiting experts and our own Montefiore professionals in clinical and adult health care, as well as older people and their families sharing their experiences. This evening, we welcome Scientia Professor Henry Brodaty, Dr. Jacki Wesson, and Eliza Baume as our experts and special guests. Jacki will introduce Henry and Eliza shortly, but first, please welcome Dr. Jacki Wesson, Dementia Consultant and Research Fellow, Montefiore. Jacki is an experienced occupational therapist, dementia expert and industry-based researcher, collaborating with others on projects such as the translation of best practice medicines used in residential care, and investigating the effectiveness of an education program to improve staff response to aggression in residential care. Jacki leads dementia care and behaviour support at Montefiore at both the individual and the organizational level. Please enjoy this webinar, and a recording will be available after the event. And we look forward to welcoming you at our other Spotlight events in the coming months. We will give you all the details at the end of this webinar about our next event. And now over to you, Jacki.
Thanks, Janine. And welcome everybody. I'm very excited to be starting off the series with a discussion on dementia, especially as this coincides with the National Dementia Action Week. Dementia Australia has released their report this week, focusing on discrimination that people living with dementia experience. It's estimated that there are 472,000 people living with dementia in Australia right now, and the report highlights that 65% of this group believe that discrimination is common or very common. In addition, more than 90% of professionals, volunteers and others not impacted by dementia agree that after a diagnosis, the person is treated differently. The impact of this discrimination and exclusion is quite huge, really. It can cause isolation and loneliness, have mental health effects and other negative effects on health outcomes. We hope that today's session might help you all get moving in the right direction and give you some guidance around how to support each other and be inclusive and a supportive community with and without dementia. Tonight we will explore the latest medical, behavioural and lifestyle interventions and research that Henry will talk to. I'll look at some ideas for family and friends to support older people living with dementia, and Eliza will highlight how we support people living with dementia at Montefiore. After the session, there will be time for questions, and we would like to highlight that we'll only be able to answer questions with general responses. We're not going to be able to give any individual advice. So our speakers tonight will include Henry and Eliza. Henry is a researcher, a clinician, policy advisor, and strong advocate for people with dementia and their carers. He's a senior psychogeriatrician at Prince of Wales Hospital, Sydney. He serves on multiple committees for the New South Wales and Australian governments and the World Health Organization, and continues to demonstrate national and international leadership and expertise in older people's mental health and dementia. This was recognised with an Officer of the Order of Australia Award in 2000, and more recently the Ryman Prize for the world's best development, advance or achievement that enhances quality of life for older people in 2016. I'll just introduce Eliza before Henry starts. Eliza is our Montefiore Behaviour Support Lead. She's an occupational therapist with expertise in dementia, aged care and older people's mental health. She's passionate about evidence-based care and understanding the person's perspective in assessing and supporting responsive or changed behaviours. She believes that the cornerstone of best practice in aged care is cohesive and collaborative multidisciplinary team alongside family and carers to support our residents. So now I'll hand over to Henry. Thank you very much and welcome.
Thanks very much, Jackie. And I will just share my screen. Here it is. Okay. So it's a real pleasure to be here. As you can see, I hold the Montefiore Chair of Healthy Brain Aging. It's been a real privilege for me to be associated with Monty. I'm an ambassador for the Montefiore, and I chair the Clinical Advisory Committee. And my mother was in the Montefiore now 13 years ago for her terminal care, and I witnessed the good care that she received here. So I'm going to talk about Alzheimer's and other dementias, but can Alzheimer's be cured? And some other updates. Now, it's a really appropriate week. As Jackie said, it's Dementia Awareness Week, run by Dementia Australia. It's World Alzheimer's Day, was on Tuesday. And a lot of things happened in this week. There's been quite a lot of publicity. The theme for Dementia Australia's campaign, a little support makes a big difference. And that's so true. We'll come to that. One of the other things that came out this week was the Dementia in Australia report by the Australian Institute of Health and Welfare. They make a report like this every few years, very authoritative. And what they showed, what they reported, is dementia is a big deal. It's the second leading cause of death in Australia. For women, the leading cause. For Aboriginal and Torres Strait Islanders, the fifth leading cause. It's the third leading cause of disease burden. And for people aged over 75, it is the leading cause. Estimations vary, but the high estimation is there are almost 500,000 people with us in Australia with dementia. And that's predicted to rise to either 850,000 or 1 million people by mid-century. So, you know, a lot of the people watching tonight will be aged over 65. 1 in 12 of us aged over 65, including me, has dementia. I don't have it, not yet anyway. And 2 in 3 people with dementia live in the community. It's not always older people. Almost 30,000 people are younger than 65 when they develop dementia. So the commonest question I'm asked is, what's the difference? You talk about Alzheimer's, you talk about dementia, what's the difference? Well, there are over 100 causes of dementia. Dementia is the syndrome, it's the umbrella term. It just means someone is losing some of their cognitive abilities, their thinking abilities such as memory, reasoning, language, to such an extent that it's interfering with daily function. So just those 2 criteria, decline in cognition, interfering with daily function. The 4 big causes are Alzheimer's disease, number 1, over 50%, vascular dementia, maybe 20%. That's problems with circulation in the brain or small strokes or even hemorrhages. Lewy body disease, an unusual form of dementia, characterized by sleep disturbances with people moving in their sleep, REM sleep disorder, Parkinson-like symptoms, visual hallucinations, falls, and rapid fluctuations in a day. And the fourth type is the frontotemporal dementia. In fact, there are subtypes, some with language problems and some with behavioural issues. So let's stick with Alzheimer's for the moment. What causes it? Well, lots of things. Is it all genetics? Well, no. Genetics make a big contribution. And mainly it's many genes making very small contributions. It's rare to have a single gene causing Alzheimer's disease. And that occurs in about 1% of people with Alzheimer's, where it's caused by one dominant gene. In other words, if somebody has it, each child has a 50% chance of getting it. It's a double tragedy because it comes on in their 40s and 50s. And the child inheritance will probably get it at the same age. But the other causes are life experiences, environment, and perhaps factors we don't even know about. I'm going to come back to those other environmental factors. So let me go to the updates. Let me start with diagnosis. Now, traditionally, well, first of all, dementia is a clinical diagnosis. The cause may be with various other investigations, but the diagnosis of dementia is clinical. And the way we do it is we make a syndrome diagnosis. Does the person meet those criteria I mentioned? Cognitive decline, interfering with function. And let me say how I do it, because I run a memory clinic at Prince of Wales. I get a history from the patient, and usually separately from someone who lives with them if possible. I examine them physically, psychiatrically. I do testing of their cognitive abilities, arrange investigations, and blood tests, a brain scan, mainly MRI for me now, and if indicated, a neuropsychological assessment and some more detailed investigations like a PET scan. Now, I'll get the diagnosis of dementia right pretty well all the time, certainly over 95%. I have made mistakes, not often. And usually if I'm seeing the patient over time, the deterioration will confirm that diagnosis. But getting the type of dementia is more challenging. So if we diagnose Alzheimer's, the most common type, just using these traditional methods, we'll get it right about 80% of the time. But if those people come to autopsy, and this is the gold standard, the pathologist examines the brain under a microscope, will only have been right about 80% of the time. But if we do some of these new fancier investigations, and this is the update part, the so-called biomarkers, then we'll get it right over 90% of the time. So what are these biomarkers? So we've had MRI scans around for many years now, but MRIs have really increased in their sophistication. So they can do functional MRI to show the brain actually working. There are MRIs that can show microhemorrhages in the brain. There are MRIs which can show the connection of various parts of the brain. We've also had PET scans for a long time. And the picture on your left shows 3 PET scans. And this is a new type of PET scan because it can image the buildup of a toxic protein in the brain, which is critical for Alzheimer's disease. It's called the amyloid beta protein, or the A beta protein. And in this PET scan, you'll see that on the left is a person with Alzheimer's disease. The hotter the colors, the more red, the more of this A beta protein, which builds up as plaques in the brain, different to the plaques in our teeth or in our coronary arteries. The one on the right, where there's no red, is a normal person without any amyloid. The one in the middle is a person with normal cognition and lots of amyloid. Hey, how does that work? Well, I'll come to that. The other biomarker is where we take a specimen of spinal fluid by putting a needle into the lumbar spine, the lumbar puncture, or called a spinal tap in the US, And we measure certain proteins. We measure how much of this A beta proteins in the CSF. Paradoxically, it goes down because it's in the plaques, or phospho-tau, another protein that builds up in Alzheimer's disease. But most recently, in the last couple of years, there are now blood tests on the horizon. And we can measure some of these toxic proteins in the blood. Some of them are specific for Alzheimer's, and some of them are non-specific for any neurodegenerative condition. So this is coming. We have it now in our research studies as one of the things we're doing. Now, here are some very odd findings. I mentioned not all Alzheimer's diagnosed clinically is Alzheimer's a pathology. About 20% show different pathology. The older the person, the less likely they'll have a single pathology. So we look at people in their 90s, virtually nobody has just Alzheimer's. Even in their 80s, it's pretty common to get mixed pathology. Some problems with circulation, Alzheimer's changes, the plaques and tangles, which are characteristic, or some of the Lewy body changes as well. And even in the last couple of years, there are new pathologies being described, new discoveries of different types of dementia. And I'm not going to go through these, just to give you some idea of the complexity of the brain and the fact that we're learning more and more about what can go wrong. For example, arteriosclerosis, which is what my parents used to talk about, what they call dementia or senile dementia in the old days, is making a comeback. It's present in 80% of people aged over 80. The other curious finding is the reverse. If you look at people's brains and look at the people who meet criteria, published criteria for Alzheimer's at autopsy, you know, they've got a certain number of plaques and tangles in their brain per high power field. 38% of them didn't have dementia in life. So you can have Alzheimer's that's diagnosed in life, but not have it in the brain at autopsy. You can have Alzheimer's at autopsy, but not have dementia in life. So what makes those people resilient? It may be because they don't have any of the other pathologies coexisting, or it may be they have more complex neural systems in their brain, which give them some protection. So most of us wouldn't care that much if we had some of this gunk in our brain, but we're able to live normally as we have before and died at 90 or 100 without manifesting dementia. Our brains are busy. They're like chemical factories. Our brains use up 20% of our oxygen and our blood flow. It's only 1.3 kilograms in our skull here, but it's busy. It's making chemicals and clearing chemicals. And in any factory, there's a bit of junk left over. That's the debris. And if we clear it from our brain, I'm going to come to that. And if we're not efficient at clearing it, over the decades, it builds up. That's why it's a disease of late life. So let me talk about post-diagnostic care. Sorry, I'm missing a slide. Let me just go back. Oh, excuse me. I made a mistake there. I'll have to go back. Oh no, it's fine. Sorry, my mistake. Oops. Let me move on to the next update. We've been doing research on people with dementia and their families. How did they feel after they got a diagnosis? And what they told us is they felt lost. They felt in a void. They felt confused. They had no idea what to do next. So we're getting better at diagnosis, but we're not so good at post-diagnostic care. This lady is Kate Swaffer. She was 49 when she was diagnosed with dementia. And she was told, give up work, give up study, get your end of life affairs in order, and get acquainted with aged care. This results in people with dementia losing their self-esteem, becoming isolated, taking on the sick role, and withdrawing. But we know people with dementia can live positively with many years. For many years, they can live well. And to do this, we need to counteract the stigma that they feel themselves, that their family or friends also experience, or society does. Remember that theme? Every bit of support helps. We can compensate for the deficits and build on the assets. Like we can use a walking stick for someone with a bad leg, we can compensate for problems with memory. We can work around activities, and that's where occupational therapists are really good at this. We need to plan ahead, legal, finances, driving, work. Our aim is for quality of life and support for the carer. We have a campaign that's coming next month. It's called Forward with Dementia. It'll be a website. There'll be a lot of activity about it, and we'll be letting you know about that. It's a guide to living well with dementia. So the title for this was A Cure. Well, do we have a cure? We have drugs for Alzheimer's. Alzheimer's being the most common, as you recall. And most of these drugs are based on a certain chemical in the brain called acetylcholine. Now, our brain, as I said, is a chemical factory. It's making chemicals and breaking them down. And the chemical that's most important for memory is this acetylcholine. And it's the one most deficient in Alzheimer's. So the drugs that work by blocking the enzyme that destroys acetylcholine, I mean, you're making it, but not destroying as much. And so that can compensate for the symptoms. But it doesn't stop the loss of neurons in the brain, the buildup of that pathology. So do we have a cure? Well, in Australia, we certainly don't. But in the United States, in June this year, this impossible to pronounce drug called aducanumab, or Aduhelm is the trade name they're going to use, Biogen is the company, was approved. And there are many other antibodies in the pipeline. And there have been many other antibodies tried which have failed previously. So how does this work? So remember this 3 scans here, and the Alzheimer's disease shows more amyloid, which is more red. So this antibody acts against the toxic A-beta protein that builds up in the brain over 20 to 30 years. What Biogen ran is 2 large studies, and they showed that they reduced the amyloid in the brain. The people in the study had something called mild cognitive impairments, like pre-Alzheimer's, or had early Alzheimer's. Now, in one of the studies, but not the other one, both studies had negative results, but if in one of the studies, they looked at the people just on the high-dose antibody, they had some cognitive benefit. Well, Biogen had multiple meetings with the Food and Drug Administration in the US, and they applied for approval. The FDA has an expert advisory committee, and 10 of the 11 people said it should be rejected. Well, despite this, the FDA gave it accelerated approval. And they based it on an intermediate outcome. They said, because we're reducing the amount of this toxic protein in the brain, that's good enough. The committee were outraged. 3 resigned immediately. 2 of the major hospitals in the United States said they wouldn't use the drug. 2 of the leading medical journals, the Journal of Medical Australian American Medical Association and Lancet, denounced it. And in response to this, the FDA announced an internal inquiry. But what's all the fuss? I mean, if it might work, why not use it? Well, it's expensive. It costs in Australian dollars, probably about $75,000 a year. People need to have an infusion every month for at least 12 months. The trial was only for 12 months. We don't know if that's enough or whether people have to keep going. But what worries people most is the side effects. 1 in 3 people get swelling in the brain or microhemorrhages. Headaches, blurred vision, confusion, disorientation. The good news is all of these things subside over time. It's not dangerous, this swelling or microhemorrhages. The limitation is we only know this works, or may work, sorry, I should say, in people with pre-Alzheimer's or mild Alzheimer's. So what about if we got the diagnosis wrong? What about if it's more severe Alzheimer's? What about if it's one of those mixed dementias or a completely other type of dementia? It's not going to work there. So I think the jury's still out on this, but there is hope. There are lots of drugs being recruited. I looked at this website for preparation for this talk, clinicaltrials.gov, and here you'll see the number of drugs in trial or about to go into trial for the different sorts of dementia. Sometimes they're not disease modifying, sometimes they're to treat the aggression or some other feature of the dementia. I won't go into this. So let me move to the last part of this talk, which is on prevention. Because that's what we all want to do. If we can't treat it, let's prevent it, or at least delay the onset, ideally till after we die. The estimate is that 40% of dementia could be eliminated if all the risk factors that I'm going to tell you about, shown on this slide, were eliminated. And it's hard to read at this magnification. So here are the risk factors. In early life, low education, contributing to about 7% of this 40%. Hearing loss, the biggest one. A surprise, only in the last few years has been recognized, 8%. Traumatic brain injury, 3%, and so on. High blood pressure, alcohol, excessive obesity. In late life, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. And some other ones that they spoke about but don't have enough evidence to talk about. Now, if you're being obese in midlife, does that mean you're going to get dementia? No, your risk is increased by 1%. If you've got late onset diabetes and on medication for this, does that mean you're going to get dementia? Maybe, but your risk is increased by 1%. I want people to keep this in proportion. It's an increase in risk. It doesn't mean a person is going to get this disease. Now, we all know the importance of education, of not getting your head bashed in, not having high blood pressure or drinking too much, and avoiding obesity. We know smoking is bad for us at any age, just not in late life. And we know exercise is good for us. The biggest cause in the United States and Western Europe was physical inactivity. But the new things are about hearing loss. The good news here is studies have come out in the last few years to show that people use hearing aids ameliorate that risk. Social isolation, this has been an area of interest for our group. And people who have fewer contacts socially, who have no one to confide in, who are lonelier, have a higher rate of dementia. Sleep. We all love sleep. The problem is, as we get older, we often have insomnia. Half of us have sleep disordered breathing in our sleep. The important thing about sleep is that gunk I talked about, the debris that gathers in the brain, is cleared mainly during slow wave sleep. Sleep disordered breathing is associated with poor sleep, and poor sleep is associated with worse cognition. What we don't know yet is whether we can correcting these things like insomnia or sleep disordered breathing, will that help? Or is it what they call reverse causality? Is it people who are building up this amyloid protein over 20 or 30 years, is that causing the sleep problems rather than the other way around? So this is a bit of a sideways, but I find this fascinating. We all make a beta protein in our brain. We all do it. And we clear it. Mostly we clear it at night via a system called the glymphatic system. Now, you didn't mishear me. We know about the lymphatic system, which is our body's sewerage system. It clears fluid and other matter that leaks out into our tissues and feeds it back into the bloodstream. And women who've had breasts removed, often the lymph glands are removed too, and it stops the lymph coming back, and the women get swelling in their arms. So we know about lymph nodes and lymphomas, but the brain's got its own system, and it's called the glymphatic system. And it's so cool, it's so neat. So the picture shows artery in red and a vein in blue. And in the sleeve around the artery is a space, which is where that sewerage is drawn out. It's fantastic. So let me finish up. The messages for all of us: exercise daily, keep your brain active, keep socially active, wear a hearing aid if you need it, have your blood pressure monitored, reduce high blood sugar, eat well, don't smoke, sleep well. That's easier to say. There's an extraordinary amount of research into dementia. We're getting better at diagnosis, better understanding the causes, understanding different types of dementia. There's much more emphasis on prevention. We're running an online trial for doing that. And reducing stigma and increasing support. And perhaps we are on the wave of the first drugs to actually modify Alzheimer's pathology. Thank you very much. I encourage you to look at our website for the Centre for Healthy Brain Aging, where I'm a co-director, and you can see some of the work we're doing in research in dementia. Thank you, Janine, and thank you, Jacki.
Thank you, Henry. Just a minute, am I unmuted? Yeah, all good to go. Thanks. We will move on to our section. Just a reminder that we will have this questions in the chat box, please. We'll try our very best to answer all of those questions. See how we go. We've got our slides, our outlines. Okay, so Henry, thank you very much. We could spend hours talking about that. I know there's so many things to talk about. However, we'll move through and try and just give people a sort of practical approach to living well with dementia. So we want to talk about what it's like to live with dementia. What's the impact on the person? What we know about dementia comes from observations of other people, such as doctors and health professionals. But as Henry said, Kate Swaffer, other advocates, I talk about John Quinn later on, but there's a whole lot of people that are finding their voice and expressing what it's like to live with dementia. So in terms of symptoms, we know about these cognitive symptoms, and this is the thinking or memory loss that we hear about. That's often a first sign, knowing that recent memory is affected first usually, and that memories for the past are retained longer. But what often goes under the radar is the sensory changes. So many people report changes in how they perceive smell, how they perceive taste, and even how they see things. So the booklet that's highlighted there is something that was written by people with lived experience, and they talk about these symptoms. People can also have changes in mood, and as Henry mentioned, some dementias present with the behavioural symptoms first and no memory loss initially. Effectively, there's a couple of things that happen. First of all, the communication skills are usually always affected in some way. The person is almost experiencing a communication disability. For example, even at the simplest level, if you're forgetting what someone told you, then the communication between you and that other person can become very strange. With time, as cognitive abilities are lost, words can become less meaningful. So we have to communicate in other ways, such as using our body language or perhaps demonstrating and showing someone what we mean. The other thing that happens is that the ability of the person to do everyday activities can be disrupted. And in fact, that's part of that diagnostic process, so that doing things that the person loves and enjoys becomes more and more difficult over time. So you might be thinking, what can we do about this? Well, we know that dementia does cause disability, This has been recognised by the United Nations only in 2016. But we do know that people with disabilities are offered rehabilitation. But this has only recently received much attention in dementia care. There are a couple of other similar terms you might have heard of called restorative care or reablement. But people living with dementia are increasingly requesting that they are offered rehab post-diagnosis. And that's the sort of thing that'll be coming up on that new website that Henry mentioned. So we've got pictures on the right there. Both of these are really useful books that give some information about what evidence-based programs look like, and they're generally effective in preventing decline and maintaining optimum function, which is really what the goal of rehab is in this context.
Jacki, we can't see your slides. I think you're going to have to share.
Sorry. Let me go back. Yeah, sorry. Here we go. Sorry about that. Can you see them now?
Yes.
Let me just go back just so that you can have a quick look. There's the picture I was talking about. Sorry about that. Yeah. That's the first slide. And here we have the rehab slide. So we've got two pictures here with the books that explain some examples of what dementia rehab looks like. But as I was saying, the most important thing that we need to think about is tailoring the approach to the person and setting goals, figuring out what areas of everyday function the person finds most important, and then setting very specific goals and figuring out how to achieve these. So I just wanted to mention an article that's written by John Quinn, who has dementia, and he describes some of his rehab goals and tools and how he's progressing along his experience. He describes what works for him, things like music and mental activities, and both of these have quite strong evidence that supports better functioning, as does exercise. So we do have an increasing body of evidence, and that's something that is moving in the right direction. Another important shift in the way that people living with dementia should expect to be included relates to their involvement in decision making. So I have to highlight that a diagnosis of dementia does not automatically mean that the person cannot give their own consent or be involved in making decisions. Essentially, it works like this. We assume that the person has a decision-making ability. If there are concerns about this, then we should investigate that separately. But we continue thinking around decision-making ability, that it's a specific skill that relates to the decision that's being made at the time, and it relates to that particular point in time where the decision is being made. So if somebody has some difficulty understanding that, this is when the support comes in. We must be giving support during the process. So that might involve having somebody go to an appointment with them, writing things down, giving written statements or diagrams, taking notes as a discussion unfolds, identifying the pros and cons of situations, or simplifying language. If the person's still having trouble, then it may be appropriate to involve a substitute decision maker for that decision, but only as a last resort, and always including the person themselves. So now let's get a bit more specific. Supporting somebody involves being in their shoes and understanding their experience. And also that this might fluctuate. People who might present differently from day to day are still doing their best to get along. I'm going to just give you some examples of what I might look at as an OT. So I might recommend that things are put in the same place so they don't get lost. This blue basket is a good example of such a strategy. So it contrasts to the surroundings, so it's noticeable. It attracts your attention, which may in itself serve as a reminder to use it. So the basket is being successfully used for those items that get misplaced most frequently. the glasses, the keys, the wallet. But then this happens. At face value, this looks like an oversized basket. A smaller basket could have been used. You can see that it's a memory skill that reminds you that there's something else that should be in the basket. That is, it's not really visibly obvious why such a big basket is being used. But then you can put in a visual reminder in the basket, so then it's very obvious that the wallet is missing. If the wallet's in the basket sitting on top of the post-it note, then you would not see the reminder. So such a visual reminder system like this can be effective because it helps clear up what the missing spaces are and what they mean. And it's only by using your memory can you effectively work out what's happening. The same thing applies to lots of things that we do during the day, like having a shower. So how do you really know if you've had a shower? Mostly it's by remembering. So tailoring support is really important. Every person is individual. How the condition unfolds is different for everybody. First, please talk to the person who is living with dementia. It's really important to check out their perception of what's going on and try and create that space of openness. You may also need to adjust your communication approach. Always encourage active engagement using existing skills and strengths, because we know that engaging in activities has benefits beyond completing the actual tasks or projects. There are studies that show that people living with dementia who have responsive behaviours or change behaviours can have better quality of life and are more settled, and so are their care partners. Using existing skills and strengths is really important, and existing routines, because it helps someone have a bit of predictability to the world. Familiarity can make us feel a bit safer and like the world is okay. Having a severe memory loss in itself can be quite unnerving and create anxiety about what's coming next. It's really important to simplify what the person wants to do, so simplifying the task and potentially simplifying the environment as well. So having a look at where the person gets stuck when they're doing something. Perhaps this step could be taken out or changed, or different materials or objects could be used in the process. So I'll give you a quick example, making instant coffee. Some people still do this. Common steps that go wrong are not filling the kettle up beforehand so it boils dry, forgetting how much coffee to use, or forgetting to put the sugar in. Now, these are what I would call the invisible steps. They're not immediately obvious, so they can easily be overlooked. So in this situation, you might, to help set it up, you might fill up the kettle yourself in preparation so that you set up the environment in advance so it's always ready to go at any time. You might use sachets with a defined amount of coffee so there's no guesswork, or you might also think about giving up sugar. There's usually some ways around some of these functional problems. The environment is really important, the environment is really important. And looking at how it can be set up can make a big difference. So using simple visual cues or reminders like I've suggested with colour contrast, making things more noticeable. The important things need to be drawn out and the less important things need to be hidden. And finally, it can take people with dementia up to 3 or 4 times longer to process information. So often when you ask a question, they're not ignoring you, they're thinking about their answer. So give people time, please. It's important that we try and slow down and allow the person time to understand and respond. So some of the things when you're with the person, you might want to, I guess, approach it as a partner, that you're pretty much on the same level, and because people can tell how your approach is looking. Let them direct you, have conversations that start with a statement or a greeting. So it's really important to think about not asking a memory-based question. It's hard to do. We often do it a lot without thinking. You know, what'd you have for lunch? How was your day? Those questions are really hard to answer, and people find it, can find it that they're being put on the spot. So bring your news, bring your statements, bring something that you can, a story. bring a magazine, something on the TV, just sit and watch TV with the person, just being with them. You don't actually have to be entertaining and filling that space, just being alongside. Even talking about items in somebody's room or in the house, it helps people reminisce. It's a starting point for some of the discussions, because we know that reminiscence therapy is quite important as well. The other thing that you can do is be a bit more physical. So we do have some COVID restrictions on that at the moment, but doing something, going for a walk where you can, even just playing some simple, straightforward physical games with balls, balloons, that sort of thing. Using familiarity is important, using objects that are familiar. So bringing the old workplace items, for example, because people pick them up and they understand those objects. It creates a sense of meaning. And doing things like actions that use objects, so sweeping, folding, sanding, wood, that sort of thing, to give the hand something to do all day. But also engaging the senses. So we know that music, dance and art, massage, smell, all of those things are really important to try and think about when you considering these things. A final word I just wanted to talk about is around language and its impact on the person who's living with dementia. It's really important because it can be discriminatory. We don't want to add discrimination as another inevitable symptom of dementia. So inclusive language helps us understand ourselves and each other in a way that's supportive, can help reduce that stigma and reduce the discrimination. So there are some examples there on the left of what you might say, and on the right of your screen, please. It's interesting. Some of these words are a bit slow to catch on because I know that there are public figures that still use words like sufferer, but people, we're trying, this is based on people living with dementia expressing how they would like to be referred to. So I guess to respect those wishes, we're suggesting that these sorts of words don't get used. Just to go back to John Quinn, he said something in this paper that was quite relevant here. He says that he wouldn't pretend to know how to advise others about addressing their attitude. However, you do need to be surrounded by people who encourage you and build your self-esteem through language. So it's quite a powerful tool, and we often have to catch ourselves, and it does take a while, but we can do it. So we'll move now to Eliza, who's going to talk about our services at Montefiore.
Hello, thank you, Jackie, and hello to everyone. Thank you for having me. So I'll just jump straight into it. So general support at Monty, positive ageing. Our interdisciplinary teams with nursing and allied health pursue a strong focus on positive ageing when it comes to care and support. And as we know, and as you know, we've just recently heard, the research tells us that regular socialising, exercise, engagement, and engaging in novel tasks are all effective ways to support the brain with healthy ageing. We offer programs through leisure and lifestyle, physiotherapy, OT, and creative therapies. And this comes together under our neighbourhood model, which provides us all with a strong sense of community where we share experiences, holidays, meals, and ultimately our home. So we have specific dementia care units. Around 50% of all of our residents have a diagnosis of cognitive impairment or dementia, but interestingly, more than 60% of those residents live outside of the dementia-specific units, such as in hostel or in nursing home, because we're actually able to support them as they age in place. So this means that if someone's in hostel care and then all of a sudden they get a diagnosis of dementia, they're not going into a special care unit. We're supporting them to stay where they are. And with this in mind, our practice revolves around catering to residents at their level of function to achieve a balance that preserves their abilities whilst offering support when needed through ongoing assessment and review. In all of our units, the programs are tailored to fit the preferences and interests of each unique person. And we can also work with our excellent volunteers to provide additional support if needed. So next slide, please, Jackie. Yeah, so behaviour support at Monty. So our behaviour support is tailored, like I said, to the person, but it's also specific to the situation and the actual behaviour. Every person is really, really different. So we like to go right back to the drawing board and figure out exactly what works and what doesn't. There really is no cookie cutter way to do this. Like I said, every person is their own unique presentation, and it takes a lot of thinking to come up with these strategies. And we do this in consultation with the person, the family, and the care team. In this initial process, we always rule out physical causes because, as we know, organic factors can cause behavioural changes for a person living with dementia, such as infections and pain. And sometimes once we treat these issues and they resolve, actually the behaviour can resolve itself. So it's a really important part of the process. And then we move on to a toolbox session. So in the first instance of noticing behavioural changes, and depending on the risk assessment, we may respond by doing a toolbox session. So this is basically a structured brainstorming session with the care team to figure out why a person is behaving a certain way and work out some support strategies. For example, if a person becomes a bit more agitated in the afternoon, we might look at putting in some physical exercise into their routine in the lead up to known times of agitation. So this is a way of reducing the potential of the agitation or the overall intensity of it. In addition to this, we would look at other ways that this person liked to relax in the past, such as listening to classical music or watching a regular TV show. So it's really important to look at those sort of historical routines that the person engaged in prior to coming into Monty. When the behaviour has escalated, we explore ways we can support the person in the moment and aim to make them feel calm and secure. Ultimately, though, like I said before, the aim is really prevention. So we want to be doing these strategies in a way that really reduces the potential of what can happen. And we look at using non-pharmacological strategies, which is non-drug related strategies. And this is what we develop in the toolbox session. So we use the session to train the staff and try to provide consistency with the strategies for a set period of time before evaluating and modifying if needed. If this isn't successful, then we may continue our process by starting a behaviour support plan, which I'll also refer to as a BSP. So from the 1st of September this year, a BSP is now actually a legal requirement for all residents who have responsive or changed behaviours, or may need or may have a restrictive practice in use. I'll speak more about that on the next slide. The care team are always able to make a referral to the dementia consultant, that's Jacki, or behaviour support lead, that's me, as well as Amy Sender, our senior OT, to support through these processes. And like all aged care facilities, we can access additional behaviour support from Dementia Support Australia, which is a national provider and a free service. So the behaviour support plan, this is a little bit more detailed. So from July this year, the Aged Care Commission and the federal government have made a few changes in response to the findings from the Royal Commission. And one of those changes related to behaviour support for people who may experience behavioural symptoms for dementia. All residents who experience these behaviours now require a BSP. That is a plan about what non-drug related strategies and supports will be used to prevent, reduce, or eliminate that particular behaviour where possible. Fortunately, this is something that Monty has been doing for quite a long time, so this isn't our first rodeo. However, we're in the process of tweaking our plans to fit with the new legislative requirements. So a BSP is a much deeper dive into the behaviour where we assess from all possible angles, and every member of the team is required to investigate using standardised assessments. So this includes further medical assessment, assessment of mental state, changes in functional cognition, falls, mobility, changes to routine, social changes, lots of things. And then the staff will come together to share their findings and further develop and fine-tune behaviour support strategies alongside any other treatments. So during that process, we may have found that pain wasn't perfectly managed. So we would optimise pain management or even change seating to promote comfort. So these are some of the things that we also look at. One of the ways that Monty specifically customises behaviour support plan strategies and activity options is assessing functional cognition. So this is a way of looking at how the person can participate and engage using the cognitive skills they have. So it's very enabling, but most importantly, it gives us some insight into how the person perceives their world from a cognitive perspective. So non-pharmacological approach is always our first line. So in general terms, the research also shows that the effect size of non-pharmacological interventions is similar to using medications. However, the risk of non-pharm strategies is much lower, and they're much easier to tailor to very specific situations. So using medications, they come with side effects, they come with costs. So it really is a no-brainer to take the non-pharm route. It's much easier for everyone. And you can also be really creative. And through this process, we continue to monitor and review our strategies over time. And if they're successful, they get put into the care plan. So restrictive practices, so this is where it gets a little bit complicated. So there's been many changes from the 1st of July this year that came into effect, and the focus of this was around use of what used to be called restraints. So the new term is restrictive practice, and there are significant changes we're implementing to make sure we fulfill these obligations. This includes working with doctors and specialists, and this brochure that's on this slide here gives you the basic information about these changes, and the main focus of the changes being to uphold the rights of the person or the resident. The legislation highlights that any use of restrictive practice is a last resort, used after all best practice alternative behaviour support strategies have been used and options are exhausted. This must be documented in the BSP and must include informed consent. So this legislation is requiring us to think about the type and amount of support given to a resident and the timing of what is offered and when. What we want to do in the first instance, like I mentioned before, is explore every possible non-pharmacological strategy, and only then can we consider medication as an option. In the past, we may have implemented both non-pharmacological and pharmacological approaches at the same time, and in going forward, in some situations, this may still be the case. However, with all medication that is deemed a chemical restraint, the legislation also stipulates that it will be continually reviewed until it can be ceased. And what you do find in dementia care is that people who are experiencing behaviours, they evolve, the person evolves, so they're not always there. And sometimes what you see, what I have seen in other care homes is that medications stay on board for a person when the behaviour has actually died out. So it's a good thing to review and to try and cease intermittently. Restrictive practice. So as stated earlier, when we're minimising all restraints and certainly don't use seclusion or physical restraint. But this is the definition of restrictive practice. Any practice, device or action that has the effect of restricting the rights or freedom of movement of a residential aged care recipient. All definitions refer to the primary purpose of influencing the person's behaviour. So that's just a little bit of information there for you. And this is the last part, really. This is tricky, but informed consent. So basically, it's a lot of hard thinking that we've just gone through, but we'd like to highlight that this is also a big change as part of the legislation from the 1st of July. And this is consent. And we've included this so you are familiar. So if it ever pops up, you can say, I've heard about this, because it's a lot to get your head around. But an aged care facility must have a restrictive practices substitute decision maker if the person can't give informed consent for themselves when it comes to restrictive practices. So as Jacki previously said, this is a last resort, as we're obliged to ask the person themselves first before a substitute decision maker is appointed. And many of our residents already have a substitute decision maker through their own appointment of an enduring guardian. Some of you may be familiar with the term person responsible, but this no longer applies to restrictive practices. And now there is a requirement to have a formal restrictive practices substitute decision maker to give informed consent for people without decision making ability. So this is done through NCAT, which is the New South Wales Civil and Administrative Tribunal Guardianship Division in New South Wales. So according to NCAT, restrictive practices are not a form of medical treatment. So this means the person responsible hierarchy for informed consent, it doesn't apply. So there will be some applications that we'll have to make going forward. Usually this is the same person who holds enduring guardianship, enduring guardian. Yeah, thank you. I hope that wasn't too much to digest.
Yeah, thanks, Eliza. Sorry. Yeah, look, I'd like to thank Eliza for that information. There's a lot of, it's a really dynamic space, shall we say, at the moment, both, as you can tell from Professor Brodaty's talk in terms of the research, but also in terms of aged care itself. And I think what we've tried to do is give you a bit of an overview of some of those things. So I'm aware of the time. What we've got here is some information, further information that you can have a look at, becoming a dementia friend. There's also some 7 tips and the discrimination reports there. We've also got a little bit of time for question and answers just at the moment. So the first question that seems to come up often, Henry, is for you. It's around food. If you could give us some advice around diet and food.
Sure.
And what happens there.
So there's a few other questions I can answer very quickly. The Biogen drug is not available in Australia. They have made application. We'll have to go through the Therapeutic Goods Administration, and then there'll be another story whether it gets subsidised. Otherwise, you'd be paying $70,000 plus a year. So there's a lot of debate about that within the system. The other one, somebody asked, could they take acetylcholine? No, you can't take acetylcholine. It'll be destroyed in the stomach. People did take lecithin, which is a precursor of acetylcholine, in huge quantities. It made them smell like a fish and it didn't work. So you can't take it. So that's why the drugs like Aricept work by, and Remedal and Exelon work by blocking the destruction of acetylcholine. The mechanisms for hearing and social isolation causing dementia, I don't know. It's a fascinating question. I mean, hearing may work through social isolation. People with poorer hearing are more socially cut off. But how that works, whether it's what I call the reverse causality, people with incipient dementia withdrawing socially, or what the mechanism is, I think is a really important question, which we're trying to look into. And there's a couple of questions about the diet. Most evidence is for the Mediterranean diet, or something called the MIND diet as well. And that's a diet that's rich in vegetables, legumes particularly, and nuts. And also there's another extra virgin olive oil is also good, but lesser amounts of red meat. Some fish is also some benefit, but it's mainly a grain and vegetable based diet with lesser amounts of poultry and cheeses. A little bit of wine's okay, but not too much. So that's it's a healthy diet we need to eat, and it's a balanced diet. There's no evidence any particular food group works. A lot of, if you go to pharmacies, you'll find on the shelf, on the counter actually, brain health, take 2 tablets every day. Who knows if they work? There's certainly no proper evidence about those things. But eating well, with particularly a plant-based diet with legumes and nuts is important.
Thank you. Thanks, Henry. There's another question about elaborating on how to help someone living alone so that they can have a shower. I guess there's a lot of questions that we can ask about that, but one of the main things is to think about all the things that the person already does, making the bathroom more inviting, making it easier to see. So things like having a white white tiles on white and white fixtures, white bath, it makes it much harder to see. So making sure that the lighting is appropriate, that there's no glare. I can recommend that you have a look at the Dementia Australia website, because you can go into each room and get some specific suggestions around that. You might also want to think about how often the person's showering. Do they really need to shower every day? What time of day? Whether you can link it with another activity. There's some of the ideas that I would start with, and making it a little bit more inviting. But to tell whether or not, you might talk about whether or not the towel's wet, where the clothes, the dirty clothes go, so that there's a very defined area in that bathroom where the dirty clothes go and where you find your clean clothes, so that there's more ways that the person is able to check, or even sometimes we use a checklist in the bathroom with the day of the week, and you tick it off, you laminate it and say, yep, I've had a shower, because it's a very easy thing to forget. The impact of lockdown and the timing and development of BSPs. Yeah, look, we know that that lockdown has had a really significant impact on people living with, on everyone, but particularly people living with dementia. So in terms of, it does impact on behavioural change as well. What we do as an organisation will be monitoring all of that and developing with the person, with the substitute decision maker and the family, and having conversations around what those changes are, and working out how to go forward with that and supporting them. In terms of the review period, we're pretty much monitoring what people are up to most days in residential care. One of our gentlemen says, people are watching me, and it's like, yes, we are actually. We're checking in to see that you're okay. So we do, whilst we might not have a formal process, a meeting every week with, say, a family member, but we certainly are monitoring it, and the team of us at Monty are always involved in checking how someone's going.
And in terms of specific strategies related to the BSP and supporting people during the time of COVID, which has been a whole new learning curve. Anyway, we have been able to use things like iPad and FaceTime, and you see staff walking around all the units with iPads in their hands, trying to connect residents with their family members. So, and I also think, full disclosure, I've been at Monty now since April. And one of the things that I've found is that the staff know the residents really well, and they have relationships with them. And so it's really hard when residents are missing family, but they also have their own community within the unit, which is really nice.
So yes, we do understand that there are significant impacts, but we're hoping that we've got some strategies around that, and certainly our engagement team, our leisure and lifestyle team and the whole care team are really quite aware of trying to help people still feel engaged. Henry, there's one more question from you about about when the blood test will be available.
It theoretically should be available now, and I think the question also asks, can you do it to predict you're going to get dementia? And I think that's going to happen, because we know from people who had that rare genetic form that, let's say they had a father or mother who developed it, say, in their 40s. They're getting tested in their 20s and finding the amyloid in their brain already present. So we know that, and we know that likely they'll get their clinical dementia 20 years later, in their 40s as well, like their father or mother had. And so in this period of the build-up, we can find some of those markers in the blood. So how long beforehand, I don't know. Could we do it in an 18-year-old who's going to get it at 80? Probably not. But could we do it in a 70-year-old who's going to get it at 80? Maybe. I think that research hasn't been come out yet. So the blood tests are available. we're going to do it through a laboratory in Melbourne in our research application that we put in a couple of months ago. Whether it's available for the community, I don't know. I've not requested it, but potentially yes. Yeah.
I've had one question about whether we can issue a certificate of attendance. Sorry, we're not going to be able to do that. It's not possible with over 160 people online, but we do appreciate you might want to put in your own reflections on attending today. I think given that it's a little bit later than what we hoped, we might wrap up now. The recording will be online, and I also would like to thank all of our team, our marketing team and our community engagement team, and Janine and everybody here at Monty, and especially thank Henry for being with us again today. And all of you online, I really appreciate your interest and hope that if you have any further questions, you're welcome to email or contact us offline. Thanks very much for your attendance, everybody.
Thank you. Good night, everyone.
Good night.
Good night.